Thanks very much, and always pleasure to come to your residence course. Seems like a lot of people this year, which is great. I was kind of, hopefully it's going to be enough, and actually it's more than we wanted, no? No,
Never enough.
You always want more. Okay, anyway, so, you listen all these fancy things, but the interesting thing is no matter how much enabled technologies you use, at the end is the anatomy, the approach, and your surgical skills. You can put as much as you can at enhancing and unenabling technologies, still need your common sense, your clinical judgment, and a really good craftsmanship. Still there is bad pilots on the airlines, and they still, and always is like that. So don't get blinded by the science. Not the song that said that. Anyway, so I'm going to go over the lateral approaches and give you a little bit of tour. What is it? But more than what is new, because Dr. Pimenta will be probably talking about the latest on lateral, which is doing in prone position and mixing with all these technologies. I'm going to try to show you the base of the lateral. So first is, don't forget, this is basically the most of the interbody fusion that we do. You do PLIFs, you do A-lifts, you do T-lifts, or you do laterals, and different ways, open, mini open, you name it, endoscopic, whatever you want to put on it. But if you look in here, and I'm trying to do like an analogy, we do like a comparison to music. I will say PLIF is like, if we're comparing to music, it's like on the old cassettes, Fine, you just put two cages, whatever. Then the A-leaf is kind of cool, it's a vintage vinyl, but, it's good, it works amazing, but it's kind of that. Then you go to T-leaf, it's kind of a little bit like antiquated, it's like a 90s, Britney Spears kind of, So you can make it work, you can listen once in a while, but you can like that. But if you look to lateral, in my own world, lateral is like, he's the newest guy on the block. I mean, it's already 20 years, I believe, so since Pimenta started doing this, early 2000s. But as you see how is the evolution of this, and most of the senior surgeons here, Charlie, you probably start training on PLIFs, correct? Or you, who else is Charlie? Who else is senior in here? Dr. Pimenta, what was the first interbody fusion procedure that did you learn?
The first interbody?
Yeah, procedure that did you learn? So it was a PLIF? Oh, A-leaf.
A-leaf.
Okay, what about you, Charlie?
PLIF.
PLIF.
Yeah.
Okay, what about you, Dr. Pat Johnson?
Probably A-lifts.
A-lifts? What about you? Who else is here?
Kojo.
Senior. Kojo?
It would be a T-lift.
Okay. Dr. Skaggs?
Young.
What, Dr. Skaggs?
Oh, A-lift.
A-leaf. What about you, Harold?
PLIF, I think.
PLIF, that's funny. We three of us probably with same generation. First thing that I remember, Dr. Green in Miami doing PLIFs, and that's the first thing, level, like PLIF was the first thing that I learned. But anyway, so let's talk about laterals. Okay, lateral is very interesting, okay? So it relies on indirect decompression, okay? You're trying to do lateral surgery and then thinking that you do a laminectomy right away. I mean, you're like, killing the monster twice, So you need, the trick is find the procedures where you can really provide good indirect decompression, get it away. There is a gap on there, and actually is getting filled very good with the new option that Dr. Pimenta is going to talk about, which is the prone lateral. Because in prone lateral, you have the position perfect to do decompression after that. But in general, just the lateral surgery, the lateral interbody fusion works by indirect decompression. You find patients with collapsed space, you open it up, you decompress indirectly, okay? Third, there is no potential for durotomies, which is great, yeah? You can tell the patients in the clinic, I promise you, you will never have arachnoiditis. You will never have a CSF leak. Why? Because we don't deal with that, yeah? You put the cage from the side, and then you put your percutaneous screws, you walk away, yeah? So, and people think that CSF leaks is not a big deal. Well, trust me, you guys have seen an arachnoiditis after a CSF leak, you will never forget that patient. It will live with you day and night. How many lawsuits you have, Harrop, on arachnoiditis? You're the king of the lawyers and that you defend people. No, I mean, you're defending surgeons. Hard Rock has like a huge, legal activities, protecting surgeons and that. Okay, there you go. See? So anyway, so arachnoiditis can be a big deal, and CSF leak actually is something else. How many of you guys consider CSF leak a complication? Everybody, yeah? So it's amazing. Okay, and then obviously,
Since you brought it up, and I'm a legal, occasionally do some legal work.
yeah, and you know what the story? This is going to be recorded forever. The lawyers are going to use it.
And I'm just going back to semantics. A complication means that something bad happened. A CSF leak is not a complication necessarily. If you have a calcified arachnoid.
You need to speak loud so the lawyers can listen to this.
I'm saying, if you have a calcified arachnoid cyst and you have to open the door to take the cyst off the nerve root, it's an adverse reaction to your operation. And so I really think you need to change the complications means you did something wrong. And it's a little
really
bit of a
good because-
semantic. So I never use the word complication unless it is a
I like it
complication.
a lot.
I use this in an adverse reaction. It's like, okay, who does it the greatest? The cranial guys never have a complication.
Yeah.
I listen to my guys that do open acoustics all the time, and we buy gold weights like they're going out of style. We'll explain it to you guys, to the orthopedic guys later. But the deal with this is they take the seventh nerve and the eighth nerve, and it's not a complication. It's part of the operation.
Yeah. So
Why is that true?
Yeah, the other good example is you do an ACDF. Next day you ask the patient if he has a little difficulty swallowing. He say yes. Is that a complication?
All right, not that I wrote a paper.
Everybody has that, So you
we-
say it's not a complication. So it may be an unexpected outcome. I'm not sure how you call that. I don't know, one of the senior guys. But
Lateral damage.
yeah, it's like the cause
You're
of the
definitely
business.
not from Philadelphia. So actually, I'm just going to go off on this one real quick second. We wrote a paper exactly what you're asking. We took 10 case scenarios and we asked people what is a complication or an adverse reaction, and then we took this same 10 questions and we asked surgeons. One of the things that we asked was, when you do occipital cervical fusion and you lose range of motion, is that an adverse event? Who thinks it's an adverse event? Well, you're brighter than 30% of the surgeons we asked who said it was a complication. It's the goal of the operation is to lose the range of motion in the neck, because that's what you're doing with the fusion.
Yeah.
The only thing that patients did not think was an adverse event was an infection, which just cracks you up, because an infection is absolutely a controllable event that you probably, it could be something we can change. So I guess perception and reality are different things. Patients, when they go to an operation, they assume that there's a risk with infections.
Yeah, so I mean that's interesting, and so anyway, so you're looking here. This is basically what you do with the lateral approaches. See, this is a classic application on degen cases, spondys. You see this case, amazing. You just regain the disc height, correct the anatomical deformity, which is bring the spondy back and restore some of this height, and you have a really good indirect decompression without the need to do any laminectomies, anything else, So the old-fashioned way, the way that I was trained, you do open the spine, do a big laminectomy, take the pars defect, whatever, and then they say you don't have to reduce the deformity because, you were decompressing everything. But if you rely on indirect decompression, you much better walk away from the OR with a full anatomical reduction. Otherwise, this patient will need a laminectomy later on. So you need to learn, which is not the scope of today, what are the what are the indicators of indirect decompression? What thing you look at when the patient is in the clinic, in the symptoms and on the images that tell you that this patient can be a good indirect decompression candidate, which is not obviously today. But you can have these outcomes, which is amazing, really good surgeries. Okay, deformity, lateral is amazing in deformity, yeah? The ability to correct the coronal deformity just by putting the cages, the ability to have the anterior longitudinal ligament cut it and do the ACR, and putting this big implant where you can have a good fusion. Lateral is really good for deformity. obviously it's not the only solution. It's just a part of the equation. As you know, the forming is a very complex problem to solve, but absolutely works. And then trauma as well, one good example in here, patients with big fragments, incomplete neurological deficit, you can go from the side, you can use these big implants with wide footprint and get a really good results. And you can even go onto the thoracic spine and start doing, tumors. In this case, for example, these thoracic discs, which I love this surgery. You see this monster calcified disc. This was like a last week surgery. Using here, huge calcified disc. You go retropleural from the side, get away from that, really good results. No BS, like in social media when they show these endoscopic things and they don't show the post-op MRIs immediately. So the story is that for all of you guys, when you do these surgeries, you have to be treated yourself. And don't get afraid to do MRIs and CTs next day. And don't come and say that my hospital doesn't pay for it, all these things that I get used to. I never have a single MRI or CT post-op denied on my hospitals in Florida, in Arizona, wherever I've been working at. So it's very good because this is the proof of your work. And not only that, it makes you better because you can find where is your bias. For example, on the pedicle screws, I'm a little more median, more lateral. This is my own bias. So it's very good because you can learn and you can always become a much better surgeon, especially technically. And don't forget, the more you get close to the perfection in your images, promise me, the patient has to be good. There is a good relation between perfect instrumentation placement and good outcomes, there are more chances that putting screws on this that you have more issues with the patient than when they look perfect. And they protect you also with the lawyers, You don't want to be the guy that at the surgery, one screw is lateral. You say, it doesn't matter, it's fine, it's just breaking on the lateral, it's on the rib here. And then the patient starts complaining of pain. Go next door, everybody come and say, oh, this is big Charlie surgeon, take a look what he does, and then they make a big deal. So even for marketing, it's important that. So you want to make sure that everything is bulletproof. Okay, so the lateral approaches are basically two variants. Or you go through the psoas, or you go in front of the psoas, So the interesting thing is the way that Dr. Pimenta conceptualized it was truly transpsoas, yeah? And then this pre-psoas procedure came in, and it was a combination of two things. One is the inability of the systems to have a directionality on the EMG. So it was very hard to go transpsoas and figure it out if you were in the front or in the back of the femoral nerve that is the main player of the lumbar plexus. So, and then it was expensive technology. So countries with not too much access and on the healthcare is not very affordable, and there is no resources. So the way is that they went anterior and trying to get in front of the psoas and start moving the psoas back and dealing less with the lumbar plexus itself. But it's very interesting. If you look at every paper, I'm going to show you later on, even pre-psoas, the number one complication is lumbar plexus injuries. You still have the lumbar plexus injuries even if you go pre-psoas. And watch this, pre-psoas is basically only for 4-5. Everybody that do 3-4 to 3, they just go transpsoas. I mean, there is nothing to injure there. Why you have to go and deal with vessels, with the ureter, all this anterior thing that can be a problem. So in general is, and I've seen over the last few years, very interesting because I'm putting a course of lateral for the next Congress of Neurological Surgeons, and I'm trying to find what we call Oliver surgeons to be on the faculty. I can't find anyone. It's like so hard, It's like, at least on the academic world, there's very little. So it's very interesting. I think it's a big current to keep doing more and more transpsoas. And at the end, you're docking anterior. The more anterior you docking, the more, so it looks like a that pre-psoas, by the way. So this Olive, that thing was actually, I think Olive at some point was a trademark from one of the companies. But anyway, so that's the story with that. And what you have to do is how can you get away without damaging the lumbar plexus? So you have to understand what the lumbar plexus is, how it goes, and this is the classic text, how you learn the lumbar plexus. I mean, you see this, you get clueless, You just go and you learn them, you make like a little smart phrase, like a Peter, drink milk, or whatever you say, and then you go and answer the test, but it doesn't work on the real life, yeah? So you need to actually live it, have it, and this in courses like this, you come in here and you're gonna do a couple of lateral surgery, but I tell you, what you should do is Once everybody's done with that station, open that incision big, get into the retroperitoneum, get to the psoas, find where the plexus is, and try to find out, okay, when I do this surgery, this is what I found. That will give you a lot of confidence. And when you're doing real cases, you're gonna find out, I know what things are, you know? So it's very good that you take advantage of these cadavers when you're doing these courses and do more the anatomy than anything else, okay? Position, you can do a lateral or prone. I have a partner in my institution actually do a supine. So when he does L5S1 A-lift, he do 4-5 in the supine positions. He doesn't need to move the patient. So instead of moving all the vessels on the access surgeon, he basically goes lateral through the muscle and put the 4-5, which is interesting. You know, obviously it's the least popular option, but right now we have the lateral and the prone is becoming more and more popular. So basically, a surgery is this. You get through the abdominal muscles into the retroperitoneum, through the psoas, negotiate, make sure that you're in front of the lumbar plexus. You know, you do it through MIS, and you don't have your eyes to check what is a nerve, what is not a nerve. You have to rely on a good monitoring system, you know, SSCPs or MEPs, but you need to have a really good system. And then you do the carpentry. And again, it's all about this, you know, indirect decompression. Get a collapsed space, open it up, reduce it, and then also, and this, what is this telling you is that you have to be very good also on the carpentry. When you do a T-lift, you use like a million instruments, curette this way, curette that way, and you, at the end, the end plates are almost gone, you know? In lateral surgery, your end plates are golden. You know, you need the end plates because the worst thing that can happen in lateral surgery is get into the surgery, put a big implant, looks beautiful under anesthesia on the side, but then the patient stand up, collapse, and then in 3 or 4 weeks, calling your office saying that they're miserable again with the leg pain and that. So why that thing happened? You were not good in terms of preserving the end plates and also going from one diaphysis to the other one and use a big implant. That's another topic of another day, but don't forget, carpentry on lateral, you're a lateral surgeon, has to be perfect. You know, you cannot mess around with the end plates. The minute that you mess around with the end plates, trust me, these patients are gonna get wrong. And after 6 months, you're gonna say, you know what? I'm gonna keep doing T-lifts and laminectomy like that. I don't like the lateral surgery, doesn't work. You know, guess what? Look at the mirror. What's you that didn't do right, you know? But you know, it happens a lot. We like to blame somebody else. We don't look at ourselves. So again, so when you do lateral, you basically, the game become controlling 3 variables. That's it. So you have to do the direction of the retraction. Make sure that you're in front of the plexus. As long as you're in front of the plexus, it's very hard to injure a nerve unless you take too much time. So the second variable is time, okay? So you have to be able to stay in front of the plexus, retract it, but don't stay in there like an T-lift, 1 hour and a half hours retracting this nerve, and you go in here and you look at the moon and you talk to anesthesia and your wife calls and the other one, you know, secretary has something. This one you have to create a system and move. I'm gonna give you like a numbers, for example. When I have one of the residents, Mike White, okay, you see how we do these cases at BNI. So once the retractor is in place, you had to be there in less than 10 minutes. And I can tell you, the fellows and the residents, when they get through it, in 6 minutes, they walk away. You put the retractor, take the disc out, prepare the end plates, put the case, see you. I promise you, you're in front of the femoral nerve and you stay less than 10 minutes, you will never have a femoral nerve injury. It's very hard because it doesn't exist, you know? You're just retracting a nerve for a time that is actually not enough to get injured, yeah? And then the last one is the amount of retraction. This is the third variable. If you open the retractor like this, great for you, but you know, bad for the patient. And to be honest, you just need to open the little space on the disc. You don't need more than that. So you need 10 to 12 millimeters craniocaudal and no more than 26 millimeters posterior to anterior. After that, everything is BS, you know. You don't want to be too high where the segmentaris vessels are. You don't want to be too anterior where the big vessels are, or too posterior where is the foramen. So just right away, and you have to control that. So again, you have to be smart, you have to be fast, and you have to be judicious. So you control, you are 3 things, promise you do it great. So just to finish, I'm gonna show you a 4-minute video of a case skin to skin, because this is all about being in a lab today, so I want to see you how I do these cases. But then, watch this. this is, you see, it's 8 instruments in here. I do the surgery with these 8 instruments. You know, everybody create their own personality, but with these 8 instruments, I do the entire case skin to skin. So basically, I open the skin, go through the muscles with 2 forceps, use the dilators to get through the psoas. Then I put the retractor, pituitary, taking a little bit out, then cup this way, cup that way, and then you put a big box cutter that do a lot of job, takes most of the disc out, and then go with a little ring curette in one template and the other one, try not to damage, put the implant, walk away. You know, not even templates anymore. So why don't I use trials? Because if I start, for example, with a patient that I collapse this space, I know that the height of that implant cannot be more than 8 millimeters. If the disc space is a little bigger than not collapse, it's 10. And after that, if you ask me what are the sizes of cages that I use, I would say 90% of them are 8, 5% are maybe 9, 10, and then almost 1 or 2 times a year out of 80, 100 cases that I do, 12 or bigger implants. So you guys are using 12 implants, something is wrong with you guys, or you're doing the wrong patient that have already huge interspace, or you are absolutely damaging all these templates, or you are over-distracting, which is not good as well. Okay, so let's see the video in here, the case. So let me see, move a little bit. So this is a case actually was challenging because it has bone in bone. You see this case, for example, the implants cannot be more than 8 millimeter height. I mean, more than that, just waste of time. Let me just get in here. Okay, this is the CT. You see this one was very challenging because it has this big calcification there posterior. This is the positioning. There is many ways to position, but I can tell you what the main goal of the positioning is: bring the spine close to the skin. That's why you put it on the side and you break it. And second, make sure that the patient is perfect perpendicular. That's the 2 principles. The spine to the skin and the patient perpendicular, so you work exactly in one point. Using here, you mark the skin. The incision never is more than 4 centimeters, which is like a 1.5 inches per level. And then using here, you open it, you open the fascia with the bobby, and take a look what happened right now. So you see a little line on there? That line is gonna put me exactly where I was marking the dilator should be. And then I start dilating with the forceps, the different layers of the muscle. You see first the external oblique, then the internal oblique, and then you see this white, nicely shiny one that is the transversalis, as you see there. It's a transversalis, you just poke through it a little bit, and then you open it, and then you see fat again. This part takes no more than 2 minutes, You 3 muscles, go through the transversalis, and you follow exactly your line that you make. That's why it's so important. If you lose the position of the patient, you start getting lost, yeah? So then using here, you put your dilator, and then the next part is using how you make sure that you're in front of the femoral nerve. So I don't want to go with my eyes and start moving fast. This is scary. Everything on the retroperitoneum is scary. I always say the less I have to see things there, the better for me. So I just go with the dilation. As long as I know that I move the colon away, then I make sure that my numbers are good. Always trying to have a good difference between stimulating posterior and anterior. Let me just take the sound in here. And then once you find that you're in the front of the femoral nerve, then you put your retractor. Using here, I like to use this 2-blade retractor, and I put this plastic barrier so I can work sideways if I need to work sideways. And then as using here, the surgery becomes very simple. This is the time when you start counting. Once the retractor goes in there, that's when the clock starts rounding. Using here, as I told you, first knife, then cup one way, using here, and then the cup the other way, and then this is the box cutter, in and out. Make sure that you don't damage the end plate with the box cutters. You see the box cutter right there. And this instrument is very interesting. It's very efficient, but you can make a lot of damage with the box cutter. They like to go anterior, so you have to control it. You don't want this thing goes anterior into the vessels or damaging the end plates. You see that, how good they come. They come with a lot of disc. And then once you do that, I just go in with this ring curette that I like it a lot. I just do the final tuning on the end plates, and then I go with the implant. That's it. So you see, I make it very simple. And that's the way that you control the retraction time and you decrease the chances to have femoral injury. And then you see the case goes, whatever you use. I'm using picking here. But, obviously nowadays is titanium is the new kid on the block. And you see here, you take the retractor, nothing is bleeding, everything looks really good. You see how the psoas closed. Now this is all the fat on the retroperitoneum, nothing is bleeding. And then you make sure that you close the fascia because you don't want incisional hernias. And that's pretty much the procedure. So to finish, this is in general what we need to do. If you look this dissection, this is what I want you guys to do after you do the lab today. Open that cadaver and try to find this big mama, okay? So this is anterior, this is posterior, this is the plexus, but actually this is the femoral nerve going out. This is 4-5. So your game is how can you be in front of this big nerve, retract it a little bit posterior and walk away from that. You don't want to be right here. This is really bad behind the plexus because you're moving it the wrong way. Or here, it's even worse, in this crotch between the nerve root and the femoral nerve. So at the end, it's all about, again, controlling your direction, your time, and your amount of retraction. And don't forget, try to do a surgery, not an adventure. If you can control all these things, sometimes you have to find a way to make the job done, but always, make sure that you have a standardization. Thanks very much, guys.
All right. Thanks very much, Juan. Any questions for Juan? We're running a little behind.
Juan, what fascia are you actually closing when you say?
That's a really good question.
You don't want to prevent.
Yeah, so ideally, if you ask a general surgeon, they tell you that you have to close the transversal fascia. Good luck, you can close the fascia, That's a nightmare. And normally, I close the fascia covering the external oblique. The problem is you're trying to put a true and true suture. This is what's going to happen. Normally, when you're doing that, the ilioinguinal and the heliohypogastric nerve, or even the subcostal nerves, they run on the muscles. If you grab it, you will have this abdominal pseudo hernia, so you don't want that complication. So I will close the external oblique, and most of the time, we'll take care of that. I haven't some incisional hernias through the years, but it's very low. And every time I have this incisional hernia, the general surgeon always come like, oh, you guys didn't close the transversalis fascia. But I think it's very hard to close. You have to have these incisions,
So I never knew about this, but what's a pseudo hernia, or why do we have pseudo hernias after XLIFs? What went wrong?
Yeah, and they come very frequently. What happens is, okay, so the abdominal wall is innervated by 3 nerves, The subcostal nerve that normally comes under T12 rib, the ilioinguinal or the iliohypogastric. That's 3 nerves, and you don't know which one is the most relevant to give the innervation here. That's why, for example, when we find the first cases of this, I was looking on the literature. There is some actually very interesting, a German paper for general surgeons doing hernias with trocars, and they were having abdominal pseudohernias, because they were hitting one of the nerves with the trocar. So that's why we always say you have to dilate the muscles with the forceps, because if you see a nerve, you just walk away. What you don't want is to do the classic GU or general surgeon guys, with the bobby through and through, because you cut one of them, and normally you don't know which one is the one that drives the main function, the subcostal, the ilioinguinal, or the iliohypogastric. Then you have the complication. And most of the time they get better after 1 or 1.5 years, but the patients don't like it. When you do thoracic disc herniations, they're very frequent because normally you work T10, T11, you can have that. The subcostal is very relevant for that.
Okay, sounds good. Thanks, Juan.
Thank you.
So we're going to skip